All right. Welcome, everybody. My name is Noah Siegel, and today Avis Garcia is presenting on our third session in our series on suicide, with a focus on helping individuals experiencing suicidal ideation. This training series is brought to you by the National American Indian and Alaska Native Mental Health Technology Transfer Center. We are part of the MHTTC network, which also includes 10 regional centers, network coordinating office, and the National Hispanic and Latino MHTTC. This project is supported by the Substance Abuse and Mental Health Service Administration, or SAMHSA. The content is developed by the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, and the American Indian and Alaska Native MHTTC. In the next couple of days, we'll send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and the CEU request form. Our center is a NADAC certified educational provider. We'd be happy to provide you with CEUs. We are currently waiving any fees for CEUs during quarantine, and when we send out the follow-up email, you can simply reply to that email and request a CEU certificate for your attendance. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. That evaluation will be sent in the chat or in the follow-up email. The survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. Also, apologies if there's any background noise. Just as I started this, people decide to start mowing their lawn. You'll be muted for the duration of this webinar, but please use the chat feature to share your questions and comments, and we will address them as we can. We will save any that aren't able to cover today for future sessions. So today's speaker is Avis Garcia, PhD, LPC, and LAT. Avis is Northern Arapaho and is an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. She earned a doctorate in counselor education and supervision at the University of Wyoming and is also a licensed professional counselor and licensed addiction therapist. For 19 years, she has been a mental health provider in the treatment of Native American youth and families. She is also an advocate of education in Indian country, a resource provider for promoting cultural enhancement of evidence-based practices, and practice-based evidence of treatment approaches for Native American children and their families exposed to trauma. Avis Garcia has more than 19 years of experience and is knowledgeable about the concerns of implementation and adoption of evidence-based practices being introduced into Indian country. Avis is currently employed as an executive director of a nonprofit Avis is currently employed as an executive director of a nonprofit substance abuse treatment center in Cheyenne, Wyoming. And so without further ado, I'm going to turn it over to Avis Garcia.
Hi, everyone. Thank you for taking the time out of your busy schedule today to attend this session. It shows that you have a commitment to suicide prevention, and what you do every day isn't easy to do. Thank you for joining to help protect the health and safety of your own community, whichever community you're working in. And today, I have a lot of material to cover and a little bit of time. I have to end promptly at 12. So if you could save any questions you might have for the very end. I have another webinar that I have to get on right as this one ends. And whenever you're ready to pull up the slides, we can get started.
So Avis, can you share your screen?
Can I share my screen?
Yeah.
Yeah, I would have to pull up the presentation though. It's not showing it. Okay.
We don't have your PowerPoint.
Oh no, I thought you had it all this time.
We had the handouts, but not the PowerPoint.
Okay.
I think it was too large to send.
Okay, I am sorry. Let me
That's okay.
go into my PowerPoint presentations and pull that up. I have it on my iPad here because we were having trouble with the notes. Hold on. Hold on. I apologize because I sent these in earlier. Okay, come on. Open up.
Yeah, so we appreciate everyone's patience. We had a large storm here on Monday, and so none of us have had power or internet or cell service until just this morning, if at all. So we do apologize that things just aren't running as smoothly as we had hoped. And instead of canceling today's webinar with Avis, I just didn't want to. I wanted to try and get this accomplished for all of you out there.
This toolbar, hold on, I'm going to stop the share for a second and then I'm going to pull the slideshow up.
Sounds good.
I'm going to go play from the start, and if I can get that toolbox to pop back down again. Okay, let me see. For some reason, the Zoom, here we've got the Zoom, and then I'm gonna do the screen share, and I'm gonna pop that up. And can everybody see that now?
Not yet.
Not yet?
Nope.
Okay. Darn it. Okay, I have play from the start. Let me minimize that. And
Try going back to share your screen.
okay. Okay, I think I know what we're having a problem with here. It's getting that on there, and then I'm on there. Share screen. Okay. Still nobody can see my slides?
Can see it. Yep, we can see it. If you want to play from the beginning. Yep.
Okay. Okay. Are we good now?
You are good. Thank you so much.
Sorry, guys.
You're fine.
I'm used to somebody doing this for me on that end.
Yep, I know. I know.
Okay. All righty. Here we go. Let me see. They already gave my introduction, so we'll skip over that. I just want to tell you a little bit about myself and how it is I came to be involved with suicide prevention and just mental health in general. Several years ago, in 1985, I had my own brother commit suicide when he was 17 years old. And I do this work in honor of my brother, and I discovered through my healing process several years ago that one of the things that helped me was to help people, and that was what I wanted to do for a career. And that is sort of how I came to being involved with suicide. And over the years, I've watched it evolve, but still there's always been this stigma and shame attached to suicide. And I think it just adds to more people just avoiding the topic and not wanting to talk about it. And it is a very heavy subject to be discussing. So I always like to remind everyone that when this is over today, that you take some time out for yourself to practice some self-care for yourself. And like I said, I experienced suicide myself through the loss of my own brother. And throughout the years, my professional career has taken me to the mental health profession. And a lot of my experience with suicide was out of my master's program, where I worked at a residential treatment center off the reservation. And part of the job requirement for me at that time was to do suicide on-call crisis intervention. And a majority of those calls that I received were for suicide intervention. And I really felt like the profession didn't do a good job of preparing us in our training program to address this. So I like to take advantage of opportunities of whenever there are trainings. And now the state of Wyoming requires all professional counselors to have at least 3 hours of suicide prevention as part of their renewal licensure requirements. So I'm glad that they're doing that now, because I feel it better prepares our people to intervene in these situations. And this doesn't necessarily mean to say that everybody has to be a clinician and has to have a degree. A lot of the trainings that are provided in communities, and they're for everyone. We've even sent our clients that are doing substance abuse treatment to the ASSIST trainings so that they could learn about suicide prevention, and they actually really enjoyed it. And I felt glad knowing they were going into those at-risk communities with that knowledge and information to possibly intervene themselves. Today, we will look at risk formulation, eliciting information, managing safety and promoting well-being, reducing access to lethal means, treatment, suicide, grief, and trauma, and making meaning. Again, part of what I'm sharing with you today is part of a session that I can do all day. I'm eliminating a lot of the interactive components because we're online, but all of this information will be available to you when this presentation is over so that you can take it and use it however you choose to. Starting with ourselves, research has shown that about 97% of clinicians' number one fear is the suicide of a client. 1 out of every 5 mental health service providers will experience a client suicide each year. This here is a model of suicide that I found in one of the books that I was looking at, and it talks about our clients. Most of these people don't want to die, but they feel like there's no hope, there's no way out. So this model looks at their perceived burden on the top there, and then their belongingness on the bottom. So a lot of them don't feel like they belong to a group, belong in their own family. They may feel displaced. So a combination of how they see themselves as being a burden to other people and not feeling like they belong just increases that thought for them to want to end their own life. This is a model that was created by Joyner in 2005 that proposes an individual will not die by suicide unless they have both the desire to die by suicide and the ability to do so. Thwarted belongingness means a sense of low belongingness, not feeling like they belong, and not feeling, like I said, not feeling like a part of a circle of friends or any other important group. The next slide here is talks about the assessment constructs. And this comes from a psychologist by the name of Jobs, who created the CAMS framework that's a part of the Zero Suicide Prevention Initiative that I shared in the first presentation that I did. And this also gives you a framework of some of the issues that people are facing when they're contemplating suicide, such as the psychological pain, the stress of feeling overwhelmed. Sometimes dealing with a small stress can just add to a lot of stress building up to the point of feeling overwhelmed, agitation and hopelessness. And for some people, it's actually self-hate. So the assessments that needs to be done takes a specific look at some of the patients, looks at their risk, and to come up with some interventions that can be done to help the clients. Psychache is a term coined by Ed Schneidman. It says it's profound emotional pain is experienced as inescapable, interminable, and intolerable. Pain tolerance is exceeded, and that's what is known as psychache, which is a common risk factor that is displayed by those displaying suicidal ideation. And these next slides that I'm going to show you are some models that I found that kind of gives you an idea of how complex suicidal factors play into the increased hopelessness that can cross that barrier there. So Starting out with some of the fundamental risk factors is the biological, which is your genetics, your sex, race, age. And when I first started looking at suicide, like really looking at it and how I could help, a lot of the research pointed out that this can be in families. And I learned that my family, that there is a line of suicide going back to one of my own grandmother's brothers. One of my uncles committed suicide. So it's been generations in my family. So having that knowledge, I feel like I've been able to share that with other family members of, you know, we're at risk for this issue just in our own family. And in the middle here, you can see all of these issues here, such as child abuse, loss of a parent, culture shock or shift, values, religion, beliefs, and of course, we always have drugs and alcohol that seems to be in the mix, which was also involved in my brother's own suicide. And then we have the environment. So all of that figures into the triggers and the final straws down the middle here, such as being in crisis, a loss of freedom, maybe they were fired or expelled from school, severe illness, major loss in their life, you know, losing a job, losing a loved one, and a lot of other things we probably haven't considered. But all of this factors into increasing this hopelessness and contemplation of suicide as a solution to the problem. I can move this out of the way, which leads to passing that wall that they can no longer cope, is the different methods of suicide attempting, and that is the by poison, using a gun, and hanging, autocide, and jumping, and any other, maybe taking pills. Okay, this next slide is called the wall of resistance to suicide. And this one is very important because when we're looking at resiliency and what can we do to increase the resistance to suicide of different populations, these are some things that will be good protective factors, which is having a counselor or a therapist available, having a duty to others. You know, they feel like they have to take care of other people. Back that up. Good health, taking care of yourself is resilience. Complying with medication. About 60% of people that attempt suicide have some mental health disorder, and 9 times out of 10, they stop taking their medication, which can increase that again. And then fear, job security, responsibility for kids, having hope, positive self-esteem, a non-chaotic environment. Maybe they have a sponsor, best friends, a safety plan, treatment availability, and of course, sobriety. So these are things that can help protect someone. This is an old acronym that's been around for several years in the suicide prevention field, and this is a warning sign known as "Is Path Warm?" And if you look here, you can see what all the components of the "Is Path Warm?" is, which is the ideation, just thinking about it, threatening, substance abuse, purposelessness, anxiety, feeling trapped, hopelessness, withdrawal from friends and family is a real common one, anger, recklessness, and mood changes. So that's the acronym "Is Path Warm?" So if you see more than 3 of these, then it's something to really pay attention to the person and see if they need some help. This here is a free resource that you can download off the SAMHSA website. This is something that I seen in one of my staff members' office, and they said it just helped them to have that there so that they knew if they ever had to ask these questions that they can give a brief assessment using the SAFE-T. And it looks at the ideation, and we're usually looking at the last month. What, do they have a plan? What kind of behaviors are you seeing? And what their intent might be, which will help you determine the level of risk they might be involved with. So this is a good, simple, step-by-step process to give a brief screening of suicide intervention. Some additional inquiry for youth: you would want to ask their parents or caretakers about any evidence of suicidal thoughts, plans, behavior changes, changes in their mood, behaviors, or disposition. Any homicide inquiry, especially when the character disordered or paranoid males dealing with loss or humiliation. And so people with psychotic disorders are at a much higher risk than most people for suicide as well. This here is a nice little risk formulation and intervention slide that lets you look at the risk level from low to moderate to high. And so, for example, on the low one here, it says it's a modifiable risk factor, strong protective factors. Maybe they're just having thoughts, they have no plans. It's just they're having a bad day, a bad week, something's going on. Possible intervention would be outpatient referral. Moderate, there may be few protective factors and a multiple risk factors involved. So the suicidality, they may have a plan, but no intent. So they actually were thinking about how they might do it. Admission may be necessary depending on the risk factors, development of a crisis plan, which we'll talk about here shortly, and giving them emergency and crisis phone numbers to use if needed. The high one here is the psychiatric disorders with severe symptoms, an acute precipitating event. Maybe they just got divorced or got some other bad news that they just made them feel like the world was ending for them. So the suicidality of this person could be lethal. It's been with a strong intent. Maybe they've actually rehearsed it. And possible interventions, you probably need to get this person into the hospital so that they could be put in a safe environment for a while. At least our state law in Wyoming is a 72-hour hold, and based upon this reassessment at the end of that determines what will take place. But research shows about, I want to say, 60% that actually get help after suicide intervention drop out, and if they show up, they maybe attend one time. This is looking at the risk. It's low if it's an acute, then there's intermediate that's in between, and if it's high. Okay, some standardized assessment tools. I forwarded these to the ATTC so that you could print them out and look at them for your own use. You could use the Beck hopelessness scale. The reasons for living inventory is an easy one to get a hold of, but the Beck scales require permission from the company, but that'll just add to your clinical judgment if you use these instruments or not. Some ways to get some information about the suicide is we have to practice asking these questions. Like I said, when I do these presentations live in person, I like to have people practice asking these questions with a partner. And for an example would be here, I'm wondering. Sometimes suicidal thinking just helps them to temporarily escape the pain that they're feeling. You might want to ask them if this is true for them. I've noticed changes, I'm concerned. Can you tell me a little bit more? I can't imagine what you're going through. I'm so glad that you told me. I would also maybe thank them for feeling comfortable enough to share that so that you can help them. And opening the door to discuss those thoughts. Sometimes people in your situation think about suicide. So, I'm wondering how you're doing, and is there something you need to talk about? Sometimes they just want someone to listen. Like I said, it doesn't have to be a mental health professional. Anyone can intervene. Types of questions to uncover in suicidal ideation would be a normalization, self-normalization. So I might say, if I was going through this, I might consider the possibility of suicide. And are you thinking about the same thing? And Symptom amplification, setting upper limits of quantity and question at a high level. And denial of the specific, listing the specific means one by one. So if they said they had a plan, they've got some pills, and they've taken some action. So getting all of the information that you can is going to be important in helping you decide how you're going to proceed. So if they say yes, they are thinking about suicide and they have a plan, we don't want to put a Band-Aid on it. We don't want to over-medicate. A lot of people are quick to think people need medication when a lot of times some people don't. You don't want to do a no suicide contract. Those are no longer a valid intervention. And don't try to convince them that life is worth living. Their opinion is their own, and we don't want to change that for them. And not to hot potato them, which means you don't want to be scared and just hand them off to someone. If you need to get help, make sure you stay with them at all times or have someone be there with them. Like I said, you do want to thank them for feeling comfortable enough to be honest with you and share so that you can help them do some problem solving. You do want to collaborate with them, letting them know you're on their team and that you will help them figure things out together, that they're not alone. And you giving them some hope is just letting them know that you have some ideas. Okay. Why no suicide contracts are dead? They typically entail patient agreeing to not harm themselves. Despite a lack of empirical support, they're commonly used by mental health professionals. And they're not recommended for multiple reasons. They're not protected medically. It negatively influences the provider's behavior, and it's not patient-centered. That's why when we say patient-centered, we want to work with that patient to come up with their plan that they are going to be open to following. So instead, what we would be doing is developing a safety plan intervention collaboratively. And the way to increase your collaboration with that patient would be to sit beside them. Use paper and give them the pen, let them write, and give them some instructions using their own words. And some people consider this to be a controversial approach, but it gives them control over what is going on in their life at that moment. And it also helps to jointly address those problems and start some problem solving on whatever it is they're facing. The safety agreement would be, how likely would you be able to do this during a time of crisis? So when we're looking at the warning signs, there is what you want to create would be a hope kit, would be their reasons for living. Some self-soothing and coping strategies such as breathing, maybe meditation or listening to some of their favorite music, whatever it is helps them to calm down. Distractions, some behavioral distractions, maybe they, watching something funny or maybe some animal pictures or something. And that they agree to social connections and peer support, that there's somebody there that they know they can rely on. And I always say at least 3 people that you can reach out to when you need some help. It could be your best friend, it could be your mom, it could be your grandpa, somebody that you go to for help. And then also professional and crisis support. You want to provide them the emergency information that they can contact if it's going to be necessary. So to begin with, looking at the warning signs, we would ask, how will you know when to use your safety plan? What are your personal flags? Step 2, we want to look at the reasons for living. I have attached the reasons for living. It's a short form assessment. You can take that and use that to get them to look at what reasons they have for living. So a high score will let you know that they have a lot of reasons for living, and a low score is something where you want to look into things further. Like, tell me, what are your reasons for living? I sat behind the scenes when I was teaching at the university, counselors we often had suicidal patients, and My teacher, I remember, was talking to one of the clients who was expressing suicidal ideation, and this kid worked at Burger King, and he got him to talking about how much they needed him and people were waiting for him to go make those burgers. And he said, he taught me that you just want to grasp at things that makes them feel like they have a responsibility and there's a need for them somewhere. So helping them find whatever it is to want to live. Some self-soothing internal coping strategies in step 3 is, what can you do on your own to prevent yourself from acting on those thoughts or urges? What helps you to calm down? When life has been really hard before, what helped you get through? And so if they can find some difficult situation they overcame, they can realize, oh yeah, I did do that. I think I can do this. Step 4 would be some distractions. What kinds of things take your mind off your problems, at least for a little while? Again, the social connections with family, friends, and peer support. Among your family and friends, who do you think you could contact for help when you're in a crisis? Who helps you feel better when you socialize with them? Who is supportive of you, and who do you feel that you can talk with when you're under stress? So helping them identify, I always say at least 3. Some providers and crisis resource information. Who are the mental health professionals in the area that you need to identify to be on that safety plan? And what crisis resources should we add? So you always want to give them the information that they can access should they need it. And as I was Googling these to get information for these slides, there's somebody on these sites. They'll pop up right away and ask if they can help you. So I was like, wow, that's kind of cool. There's actually someone watching this site. Same here. This is also known as a virtual hope box. It is a free tool that anyone can download. And in this thing, they can put their 3 people with their pictures and their phone numbers. They can put information on their warning signs that they need to be taking care of themselves. They can put their coping strategies in there. It's a really neat free tool. I even use this in my substance abuse treatment program for my clients and to show them how to use this for themselves. Again, giving them all the information they need if they need to reach out. Sometimes they're not at a high risk and I'm sending them home with family. So I make sure the family is aware of, we have the safety plan in place. Here's the crisis information, you know, letting them know that I think this person is okay to go home, but they need your support right now. And a lot of times, especially in Native families, they really do want to help their family member. And your documentation is very important. So you want to make sure you document as much as possible as to why you made the decision you did and how you came about that. So you want to look at the risk factors, ideation, the planning, writing down the pertinent negatives, you know, the client denies that they're having any ideation, or you couldn't locate their file. So anything that you need to add that's important. Updating that safety agreement and the collaborative sources, referrals, and follow-up. Like I said, a lot of them don't return. They come in crisis, but a lot of them, even though you tell them, you know, I want to hear back from you, I'd like you to come back, they don't. But sometimes it's good if you can ask one of the family members, can you follow up with us and let us know, you know, that everything is going okay? And also sharing with your peers the situation that you experienced and how you handled it. Sometimes it's good to process this as a team, if you work as a team. The next thing that is really important is reducing access to lethal means. So that means we get rid of the pills, we get rid of weapons, guns are put in a safe place. This is a theory called the means restriction theory. It is a model here that shows you how reducing access saves lives. So what we want to make sure that we do is using, maybe not necessarily offering another method, but denying them, delaying that attempt, and so that they seek help for the suicidal crisis here. And sometimes talking to them about getting some help is helpful. And then the overall suicide rate drops. And this is just a model that shows if we can reduce that access by getting them some help, it helps in the long run if we're able to do that. But then, like I said, a lot of people don't tell. I've been doing drug and alcohol evaluations for, gosh, probably the 19 years that I've been working. And in the assessment, we do ask about suicide ideation. And from my personal experience, I would say about 75% of people will tell me that they have attempted suicide, they got help, or they didn't get help, they never told anybody. So there's a lot of people that have acted and haven't told anyone. So that is where now I'm required by CAR standards to further assess that person and have it documented in their file. This is impulsivity and suicide, the time between the decision to act and taking action. So those that were attempted suicide said it took them, 24% said less than 5 minutes, and 47% said it took them an hour or less to make that attempt. So it doesn't take long. So it's real important that we can intervene as soon as possible. One of the next intervention is called CALM. It's counseling for access to lethal means. So we want to negotiate with that person. For example, I had a young girl who had some pills, and I had asked her if there was somebody at home that I could talk to on the phone, and that, you know, if she would go home and give those pills to them, and, you know, call her parents, because she was in college at the time, and let them know what was going on. She was struggling with, you know, just going against her parents' wishes for her career at that time, and that was pretty traumatic for her. Expressing concern about their plan and exploring all means they might possibly have access to, and doing what you can to reduce that availability. Like I said, take those things away or remove them from the home altogether. And is anything on hand? Was this a temporary situation? Is this going to be a permanent situation? And if there's other people involved, you need to let them know that you need them to have 24-hour supervision of that person. And sometimes I have families saying they can't. And that's when I have to look at holding them. So you have to be able to decide if they're going to be able to go home, or we need to keep them here because they're not negotiating with you or offering to work with you on this. For me, that just puts red flags up. And then getting their safety plan. But if they're willing to go along with you on all of this, then I would say they're on the low scale. Keeping their environment safe. What means do you have to access to and are likely to use to make a suicide attempt? How can we develop a plan to limit your access to those means? Again, maybe we need to get somebody to take the pills away, or take the guns to some other place where they won't be accessible. And then a little bit on the treatment. Treating them with dignity and compassion and giving them some empowerment. Again, collaboration, you want to work with them. You want to feel like you're a team with them. Hope and collaboration. Do you think you would be suicidal if you were less miserable? Let's work together to make you less miserable. This is a quote from Ursula Whiteside. Just helping them feel comfortable to work with you and try to take some of that burden off from them. Here's another quote that might be helpful. Before you take your life to end your pain and suffering, let's try to give clinical treatment a reasonable chance to help you find other ways of coping. Obviously, there are many options, like suicide, that you can reflect on later without my help. But getting them to consider cognitive behavioral therapy, going into, maybe we want to take this person to and combine our cultural ways into the sweat lodge. And where I come from on the Wind River Reservation, that's exactly what we did, was we did invite them to a sweat lodge. That was one of our interventions we had available on a weekly basis. Importance of preserving choice and dignity. People that are experiencing suicidal thoughts feel that they're at the mercy of life, but there remains one aspect of life which they remain in total control of. They are the ones who decide whether they will live or die. The choice for suicide provides a chance for dignity via the conduit of self-determination. And this is from Sean Shea. Additional best practices in suicide management. Look for practices that are suicide specific. I'll share a couple of resources when we get further here. Time limited, but often increases with contact. And the goal that we have is to keep them out of the hospital. So that safety plan that we do with them is probably the only thing they're going to have to take with them, because I told you a lot of these people are not going to come back. So as long as we know they've got their plan and they're going to use it and they were involved in it, they're more likely to use it. So if we can keep them out of the hospital, that helps. Help them increase their tolerance and their coping skills to whatever psychological pain they're experiencing, and help them making their life worth living. This here shows the ideal situation if you're going to be talking to a family or doing your assessments. This is the old way of restraint and isolation and loss of civil rights. When they get hospitalized, this is usually what the room looks like. Somebody might be sitting at the door. They have people that volunteer to watch the door, to watch the client. There'll be absolutely nothing in the room. So that doesn't look very inviting, does it? I really feel like it's kind of scary just to look at it. But ideally, you would want to have a room environment, like a living room, a nice, comfortable, safe place where people feel not like they're in a psych unit on this other side here. So if we can create some room in your area where you work, this would be really helpful to have a place to take them that's comfortable and inviting. And so as far as for recovery, when they're out of crisis, some good interventions to have involved is dialectical behavior therapy, peer support. Right now, the Zero Suicide Initiative is learning, and I attached a book here that's free for you guys that I got for free that helps you respond to clients after the suicide has subsided and how you can help that person. That is a good tool. But they're using survivors now to help people as peer support. And I think that's really neat because they're able to share their experience, motivational interviewing, getting them from suicide to hope. RAP is a wellness recovery action plan. And I added ceremony. I know that these things worked in my community and still work and have been working for years. So, I rely on my ways of healing in my own community. And the goal here is to understand the meaning behind the suicide, what purpose did it serve, and building a fully engaged life. This is a book that I recommend clinicians have in their office. I really like it because you want to help them focus on addressing those issues that might have led them to feel like they wanted to commit suicide. And these are some really good, they come in a variety of topics, but I like how specific this one is on suicide intervention. So I thought I'd share that. And another one that's really highly recommended is Helping the Suicidal Person, Tips and Techniques. And then this other book here is the free one that I've attached as one of the attachments that talks to you about responding to grief, trauma, and distress after a suicide. Some other interpersonal regulation. They call it non-demand caring texts. So, even if you can communicate with them by text, maybe letting them know, hey, can you check in with me? Can we exchange numbers so you can check with me? I have a Google number that you can create for free. So that's the number I give to all my clients and stuff, so people aren't contacting me on my personal number. Increased scheduled check-in meetings. Sometimes our youth are more willing to do FaceTime or get on the internet with you. So as long as you know they're doing okay that way, this is one way to use technology. And for some people, we do have to get them to consider voluntary hospitalization so that when they know they're feeling a certain way. And I have had clients go check themselves in because they did feel this way, and they said that that was what they learned in getting help for themselves. So I was glad when they took that step on their own to go check themselves in, because a lot of these people with psychiatric disorders can be believing that they're actually hearing messages to go hurt themselves, and the most safest place for them would be the hospital. Okay, we're getting close to the end here. Like I said, don't forget to practice your self-care. And I am planning to get more into some grief and loss and another tool called the Columbia Suicide Severity Risk Assessment in another session. I use it at my office, and I realize it just takes a little more training. And if you can access it from the Columbia Lighthouse Project, they have a website page that's got lots of free resources. But I will probably follow up with another session on just using that Columbia Suicide Scale. But I attached it for you guys to take a look at. And again, I want to thank all of you for taking your time today to listen and share this and take action in your community. You know, our people need you, and I'm glad you're there for them. So if anybody has any questions, I have a few minutes before I have to sign off and go to my next webinar.
Thank you, Avis. You guys want to put things in the chat, you can, and we can read them, or you can just directly unmute yourself and ask. But she does have to leave promptly for another training. Thank you.
I seen a hand pop up a couple times as I was talking earlier, so don't be afraid to ask your question if you have any. Okay, Lori?
Yes, I was just wondering, thank you so much. What a wonderful presentation this was, Avis.
Thank you.
Beyond what I was expecting, so I appreciate it so much. What I'm wondering, I have a safety contract that I've been using, but I've never really been thrilled with it. Do you have anything that you could share that might be a little bit more than what I have, which is very, very short, and it just doesn't really do the job?
Yes, I do. And I didn't attach it, but I'll have to search through my files and get that to you guys. Like I said, I use this in my treatment program, and I just present it to my clients in recovery as a safety plan. It's really their relapse prevention plan, but it still includes all of this information, you know, of taking care of yourself and who you're going to call when, instead of for them when they feel like using, but when you're feeling suicidal. So I'll look up that safety plan. There is one that's kind of like a template that can be filled in that I can share. And I apologize, I didn't attach that, but I do.
No problem. No problem. Thank you so much. I appreciate it. Have a beautiful day.
Thank you. You too.
We did have another question, Amos. It says, does suicide differ from the severity of depression or on anything else?
Differ from the severity of the depression? And meaning if the depression is really severe, they're more suicidal. And that's how I'm taking this question. And I would say yes. Like I said, 9 times out of 10, I encounter clients that have gone off their medication and had been diagnosed in the past with depression. And for me, it's a real clear red flag that we're looking at some depressive symptoms in somebody who may have never been diagnosed, especially if it's an adolescent, because they're reaching that age where they're starting to feel those feelings but don't fully understand it. And when they don't know how to talk to somebody, which a lot of them don't, like I said, they don't want to die, they just don't know how to ask for help. So they just further isolate themselves and withdraw. And so when people aren't paying attention to the warning signs that are there, or something's wrong with Jimmy or Susie, you know, kind of concerned. So it's always good to, you know, check out your own family members and make sure people are okay.
Thank you, Avis. We have time for one last question. Have you ever worked with military veterans?
Yes, I have. I worked on the Air Force base here in Cheyenne for about a year. And sadly, while I was there, they had about 3 completed suicides on our base, and they're still working to try to address it by using the assist trainings. On the reservation where I come from, we from time to time offer that assist training, and we have teams of people that use their little assist cards, and I myself will go attend it again just to stay, you know, keep the stuff ingrained in my brain so I can be able to handle these situations. But yes, I have dealt with veterans, and a lot of them, it's just like everybody else, our personal problems and not wanting to tell anybody. For veterans, they're afraid to lose their weapons. So it's a real tough line to walk with them to see where they're really at and how much help they're going to need.
Okay. Well, thank you, Avis. I hope you take care. I know you have to go. For everyone else, thank you so much for joining us and bearing with our technical difficulties. Please fill out the GIPR evaluation if you have a moment. It's very important to our center. And we really thank you for joining us today. This will be available on our website soon. So look for that if you want the recording and any handouts. Okay. Thank you, Noah, for your help and assisting today.
Yes, thank you.
And everybody who joined. Okay. Have a great rest of your Wednesday. Thanks all.
Bye.